Hi, I'm Dr. Anna Brandon, a specialist in women's mental health. I'd like to personally thank you for showing interest in our study, partner-assisted therapy, or antidepressant treatment for antenatal depression. This project is to compare two ways of treating depression when it occurs during pregnancy and the postpartum. You were invited to take part in this project because you are pregnant, between the ages of 18 and 45, and diagnosed with Major Depressive Disorder. Joining this project is completely voluntary, so if at the end of this presentation you decide that you don't want to participate, there's no impact whatsoever on your care here at the UNC hospital or clinics. You can also join the study and withdraw later at any time. This won't affect your relationship with the researcher, your clinicians, or health providers here, or with the hospital. If you happen to be associated with UNC in any fashion, your decision to participate or not to participate will have no impact whatsoever on any university relationships. Before I talk more about the project, let's take a minute to talk about what research is. Studies like this one are designed to help answer questions about how people get sick, what treatments are most helpful, and whether or not one type of treatment is better or has fewer side effects than another type of treatment. Because you are expecting a baby, researchers have special protections to ensure that you know everything you need to know about the risks and the benefits to both you and your baby that could result from taking part in this study. In fact, this video is one of those additional protections we're including in this study with pregnant women. We're inviting about 40 women just like you to help us find out if one treatment, antidepressant medication, is better, equal to, or not as good as the other treatment, psychotherapy. This is important for us to know because some women and their doctors prefer to stay away from medication during pregnancy. But before we talk about the treatments, let's spend a minute talking about what depression is. An episode of depression is diagnosed when someone has either or both sadness and loss of interest, along with some other common symptoms. It's important to keep in mind that any person might have one or two of these symptoms at times, but you could be having an episode of depression if you have at least 5 of these symptoms at the very same time. They occur most of the day, nearly every day, for 2 or more weeks at a time, and they keep you from being the best you can at work, at home, and with your friends. Depression itself, when not treated, can pose problems for both mother and fetus. So when trying to decide whether to get help or not, it's important to be thoughtful about what your symptoms are, how bad they are, and whether they are keeping you from taking care of yourself. So far, pregnant women have used both medication and psychotherapy for treating their depression. But these two treatments have never been compared in research like this. So we don't know if one works faster than the other, better than the other, or if women like one type of treatment more than the other. Antidepressant medications have been used for more than 20 years for treating depression in people who aren't pregnant. As a result, we have quite a bit of information about what happens to women and babies who take these medications. So far, across all research, only one medication has been slightly associated with heart defects in babies, paroxetine or Paxil. For this reason, this is not one of the study medications. If you are in the group of women who receives medication, your medication will be chosen on the basis of your symptoms, the safety information that we have right now, and if you've taken medication before, what worked for you then. Psychotherapy, or talk therapy, has also been used for many years to treat depression. It involves talking with the therapist about what you think may have contributed to your depression, problems that you might need help thinking about, and strategies to help you cope with stress and negative emotions. If you are in this group of women, Your partner will come with you to each session and learn how to help you with your depression. We'll talk more about this in a few minutes. If you think that you don't want any treatment at all, you can remain in this study if you would be willing to visit us regularly so that we can monitor your symptoms and make sure you get help if you need or want it later. Here to tell you about some other study details is Rebecca, a woman who is also thinking about joining the study.
Because I work and I'm really busy at home with my first baby, I wanted to know what was going to be involved. Dr. Brandon told me that I would need to visit either the study psychiatrist if I'm in the medication group, or the therapist if I'm in the psychotherapy group, for 8 visits over a 3-month period. Then I'd just come in for rechecks once a month until the baby's born. After I have the baby, I, or my husband and I, will come in at 6 weeks, 3 months, and 6 months postpartum. From the beginning of the study to the end, I'll fill out questionnaires about how I'm doing at each visit. These visits will take anywhere from an hour to about an hour and a half. Since I'm about 7 months pregnant right now, that means I'm going to be involved in the study for about 8 months.
You may be wondering which treatment you'll get, right? One of the important things to understand about this project that makes it different from the treatment you might get from a doctor is that you will be randomized to one of the treatment groups. When you participate in what we call a randomized trial, you won't be choosing which treatment you receive.
Yes, they describe randomizing like tossing a coin. If it's head, I'd get the antidepressant medication, and if it's tails, I'd get psychotherapy. Except they use numbers to make the assignments instead of coins. I had to stop and think about this. I usually choose what treatments I get, so this makes being in a research study different from just going to your own doctor.
When we aren't sure if one treatment is better than another, or if one treatment has fewer side effects, this is how we answer those questions. And it's an important thing for you to consider before you decide to participate. Will you be willing to accept either treatment? Because you have the same chances of being assigned to either group. Another important thing for us to talk about is what we will do if the treatment you are randomized to doesn't work for you or gives you side effects that you can't tolerate. In that event, you will meet with the study doctors and decide if your treatment should be changed and what treatment you would be willing to change to. You will stay in the study and we'll keep careful notes about what didn't work for you and what was changed. Now let's talk about the treatments in this study. Here to tell you about what will happen in the antidepressant treatment group is Dr. Samantha Meltzer-Brody, the study investigator who will be managing this part of the study.
So let's review what you can expect when you enter the medication treatment arm of the study. The first thing we want to do is to carefully review your symptoms and your history. And we would want to review how you've responded to past treatments, if any, and review what is considered most safe during pregnancy at this time. If you have previously taken antidepressants, we're very curious to know what has worked in the past. And so we will pick something based on what has had the best efficacy for you, what has had the lowest side effect profile for you. And we would start with that medication, assuming it's something that we also think, according to the evidence, has a safety profile that's compatible with what we want to do in the study during pregnancy. If you've never taken an antidepressant before, in general, we would start with sertraline, which has shown a good safety profile during pregnancy. It is also considered to have the least transmission during breast milk, in breast milk postpartum, which makes it a nice medication to pick because you don't need to worry about switching things in the postpartum period. We will start at a very low dose of the medication, whichever one it is, and titrate upward over time until we see a response. We will want to see you every week for treatment. At each weekly visit, we will be monitoring your response to treatment, we will be assessing for side effects, and we will be seeing if there's any other concerns that have been raised. We also want to make sure that your symptoms are not getting worse and that continuing with this treatment makes sense. After the first 4 weeks of treatment, if you continue to be moving in a positive direction, we would keep increasing the dose until the point where your symptoms were at least 50% reduced. At that point, we would decrease the frequency of visits, going to every 2 weeks or every 3 weeks. And our goal overall is to see that you have a robust response, that you have at least a 50% reduction across the board in all the symptoms you were experiencing. And furthermore, we're actually hoping to get you in complete remission, if at all possible. So we will treat you weekly and then spacing out after the first month to every 2 weeks for the entire 8-week duration of the treatment arm of the study. There are a number of antidepressant medications. They have been widely studied that appear to be safe, that don't appear to be teratogens, meaning that they cause birth defects in the first trimester, and that seem, if you look at the overall risk-benefit ratio, to not cause long-lasting issues. There are concerns that have been raised about neurobehavioral sequelae or neurobehavioral symptoms at the time of delivery, and that perhaps the babies can show withdrawal. But this, in general, is seen as very transient and without causing long-lasting effects. However, I think that the decision to treat during pregnancy always needs to be one that's carefully considered, and that the patient and her treating physician have a careful discussion about what the options are and what she can expect in terms of her individual story. So at each visit when you come in, we are going to be concerned with how you've been feeling. We want to assess your symptoms. We want to assess side effects. We are going to do this by asking you clinical questions, but also by having you fill out rating forms that will ask detailed questions about adverse experience that you may have had and about the symptoms you've been having. You can expect each study visit to take about 30 minutes for the part where you talk with the study coordinator, with the clinician, and the time spent filling out the forms.
If you are in the partner-assisted therapy group, you will visit with your psychotherapist around once a week for 8 visits. We've built a couple of extra weeks into the study in case you have to reschedule a visit if something comes up. But we expect that you will have all 8 visits within a 12-week period of time. Each time you visit, you and your partner will fill out a brief questionnaire about your symptoms. We'll talk about these during our session. About 6 weeks after your baby is born, you will have a follow-up session with your therapist to check on how you and your partner are doing. There have been no reports of bad effects of psychotherapy on a fetus or a baby, but it's possible that during psychotherapy you may talk about problems or things that have caused unhappiness. If you ever want to stop the conversation, take a break, or change the subject, you just have to tell your therapist. Many people believe that psychotherapy has helped them think through problems and find ways to cope with stress. In partner-assisted therapy, your partner will be able to ask questions about what he can do to help you. The main goal of psychotherapy in this trial, though, is your depression. Regardless of which intervention you're in, some of your visits will be video recorded. This is so that the study investigators can make sure that the treatment visits are following the structure for that treatment. These videos will be collected digitally, only watched by certain members of the study team, and destroyed at the end of the study. If you want the video to be turned off while you talk about something that is sensitive to you, just ask your clinician to turn it off. All patients in both conditions will also have a few extra interviews and forms to fill out at specific time points in the study. The interviews will be short checks about your symptoms with a clinician like Caroline, who won't know which group you are in.
This is to make sure that we are consistent with measuring how the participants improve and make sure that the study doctors aren't trying to make one group look better than the other. It will be important for you to help Dr. Brandon and Dr. Meltzer-Brody by keeping this secret when you talk to me so that they can answer the question about how these treatments work. You will also fill out several surveys on your study iPad. They'll look like this. They will ask questions about how you're feeling, about your relationship with your partner, and about your general quality of life as you go through the treatment. This information will be completely anonymous, and you will never be identified by name or personal information. You will have your own private logon, and the measures will be identified only by a study number that you will get when you agree to be in the study.
This is another way the study is different from my visits to the doctor who isn't doing research. I don't usually have to fill out these extra forms. but I understand that this is what it takes for doctors and patients to learn more about what illnesses are like depression. What we do in the study could possibly help other pregnant women and babies later on, although that doesn't mean that we shouldn't consider what our own personal risks are and the benefits are of participating.
In addition to what we've said about the risks and benefits of each of these treatments, there are general risks and benefits of just being in the study. One is a risk of losing confidentiality. Although we will take every measure we know to protect your anonymity, and our university's protections on the use of the internet and storage of data are as strong as possible, there are always slight risks to losing confidentiality. We will even apply for a certificate of confidentiality from the National Institute of Health, which further protects all of the data from being released to most outside individuals or agencies unless you ask us to release information. But someone might see you visit the hospital or your therapist, for example. We wouldn't be able to control that. And in this electronic age, some new way of breaking into a database could be hatched by a criminal. But that is why we don't identify any of the surveys with your name. The only place your full name is linked with the study will be on the consent form that you sign, and that will be stored in a different place than any other study information. On the other hand, there are some benefits to being in the study. Your study visits will be completely free and will not be filed or passed on in any way to your insurance company. Even if you decide to not have treatment but participate in the study, you will have better monitoring than someone who doesn't have anyone watching over their depression.
We'll also receive a $25 gift card to Target after each of the 5 visits where we have to spend extra time completing surveys. This is to offset any cost of transportation or parking we might have, as well as the extra time we spend completing them.
Now we've come to the end of this presentation, and we hope it's answered the important questions you have about participating in the project. Remember, if you choose not to participate, you may still be treated here in the psychiatry outpatient clinic or in your home community. In a minute, you'll be asked to complete a survey of questions about this presentation. Your answers will help us speak to other pregnant women who may want to take advantage of research opportunities when they arise.
And one of our research assistants will be available to answer any questions you may have as you complete the consent form that records your willingness to participate in the study. And thank you for helping us fight depression when it happens to women like you.